There are few examples in modern medicine of a compound's reputation declining as dramatically and, arguably, as unjustly as niacin's over the past decade. In the 1950s through the 1990s, niacin was a cardiovascular heavyweight, one of the most effective tools available for modifying blood lipid profiles, studied extensively, prescribed widely, and credibly associated with mortality benefits in landmark trials. By the mid-2010s, it had been largely abandoned by cardiologists and dismissed by much of the medical establishment. Understanding how this happened and why the dismissal is scientifically questionable is essential for anyone trying to evaluate niacin's real clinical value today. The Coronary Drug Project, conducted in the 1970s, provided some of the most compelling early evidence for niacin's cardiovascular benefit. Participants receiving niacin showed reduced non-fatal myocardial infarctions during the trial, and a long-term follow-up conducted years after the trial ended found that the niacin group had significantly lower total mortality, an effect that persisted even after supplementation had stopped. This is extraordinary data by any standard, a nutritional compound producing durable mortality reduction years after the intervention ended, suggesting real biological changes rather than temporary pharmacological suppression. Then came the statin era, and with it a shift in how niacin would be tested. The AMHI trial, published in 2011, randomized patients already on statin therapy to receive either extended-release niacin or placebo. The trial was stopped early because niacin showed no additional cardiovascular benefit in this population. The HPS-2 THRIVE trial, published in 2014, found similar null results when niacin was added to intensive statin therapy, with some concerns about side effects including bleeding risk. These results dealt a severe blow to niacin's clinical reputation, and prescribing plummeted. Many guidelines quietly removed or downgraded their niacin recommendations. The problem with using these trials to dismiss niacin broadly is methodological. Both trials tested niacin as an addition to already intensive statin therapy in patients whose LDL had already been driven to low levels. Niacin's primary lipid mechanism involves reducing LDL production and raising HDL, but if LDL is already optimized by statins, there's little room for additional benefit on that dimension. The question these trials answered is not whether niacin is effective, it's whether niacin adds benefit on top of optimized statin therapy in patients who may not need additional LDL lowering. These are importantly different questions, and conflating them has driven clinical decision-making in ways that may have harmed patients who could benefit from niacin as primary or alternative therapy. For individuals who cannot tolerate statins, a not insignificant population, given statin-associated myopathy and other side effects, niacin remains one of the most effective alternatives available for comprehensive lipid management. For patients requiring HDL elevation, which statins barely influence, niacin's 15 to 35% HDL raising effect is virtually unmatched among readily available compounds. The rehabilitation of niacin's reputation doesn't require ignoring the AMHI and HPS-2 THRIVE results. It requires reading them accurately and refusing to extrapolate conclusions that the trial designs don't support.